Hello everyone. So the next presentation that you're going to hear is related to one of the most important projects, the main project that the Sickle Cell Disease Association of Canada has been working on. When SCDAC was founded in 2012, the first thing we did was engage our policymakers in Ottawa. And we went with a long list, and at that time, as Senator Cordy said earlier, Laurie was the president. And we had a few demands on our list. And one of them was a national registry for sickle cell disease in Canada. And that's when they said to us, wait a minute, we don't even know what sickle cell is, and you're asking for a registry. You gotta educate, raise awareness first about it, and then we're gonna move to that. So that's what we did. That's why Senator Cordy introduced the bill that became a law, making Canada the first country in the world to recognize June 19 as Sickle Cell Awareness Day, following the recommendation by the United Nations. And since that, we've been waiting, we've been advocating, we still don't have the registry. I will tell you in my own language as a warrior mom and not a physician, you know, what a registry is. In my older life, I used to work for, I'm a federal servant, so I work for Statistics Canada. And in my work, I collected data for years on the field, and I even went to the Inuit land twice to work for the government. And one of the things Statistics Canada does is collect data for the government. And the first time I was going to the Nunavik, what they told us, we were a team of 6 staying for over 7 weeks there. They said every decision that the government of Canada is going to take for the next 5 years will rely on the data that you're going to provide. So take this job seriously. It means education, housing, healthcare, everything that was going to be done in that area of the world was relying on the work that we're going to do. That's when I understood the importance of data. So if we don't have a registry, it means we are not counted in the system. Nobody knows who we are, how many of us, where we live, the disease burden, how it impacts our lives. And that means also somebody else is controlling the narrative because we are not able to demonstrate how sickle cell is affecting us. When you enter the sickle cell community, you have 10,000 stories. Yes, we have stories here. We can spend days sharing our stories, but it doesn't, it has to be translated in the way that can be used in front of our government to make sure that we get the changes we need, we get the resources allocated to sickle cell. So now I'm going to let Alvin take over, and we're going to get to this presentation. Thank you.
Thank you, Eva. So our next presenter is Dr. Pakhale, and Dr. Pakhale is a respirologist and epidemiologist at the Ottawa Hospital and the Ottawa Hospital Research Institute at the University of Ottawa. Dr. Pakhale is going to be talking about the Canadian Sickle Cell Disease Registry. Welcome, Doctor.
Thanks a lot for giving this podium for me, but most importantly for the organizers and Biba for organizing this excellent event where all people across the globe could come and attend. So without further ado, because we are running late, I guess, and it's all Alvin's fault. So first and foremost, we acknowledge the territories and lands where we are in and honor the generations before us and in the future. And I always say when we work in Ottawa at the Bridge Engagement Center that we are paying rent to the wrong owners. These are my disclosures because they fund our research, so that's what I put them, but otherwise I don't have any pertinent disclosures for the presentation. And I work with community members like Ted and Kelly, and we miss them dearly as we lost them during the pandemic for the reasons the same we are here for, the inequity and the social determinants of health. So we will try and cover these objectives to learn about the inequities through the lens that we envision at the bridge, and highlight some of the manifestation, but I wouldn't spend a lot of time because we learned a lot of about it already through the morning, and how we make the advocacy and the policy changes, and then introduce the first and the only Canadian Sickle Cell Disease Registry that we have launched. So the health inequities get described in different ways, and there are different definitions of it, but this is one of the WHO definition, but we here in this room know and live and breathe the inequities. And what we mean by inequity and what we want to do about is to bring on the justice. And that's our goal. The justice is the goal as depicted here. So as we know, the sickle cell disease affects a lot of people, and we don't even know how many because we don't have the statistics. We know little bit data from Ontario that about 80% fall in the lower socioeconomic, but we do not know the detailed demographics because we do not have that data. And we need that. So though there are multiple presentations and multiple genomics, we do not have statistics on those, so we do not count the sufferings of these people, because even with the traits they suffer with pain crisis. So all these known since so long, and yet we do not have curative therapy, is a shame on humanity. And that's why it is a shame, because the gene was known, the cause was known, the clinical presentation was known, the suffering was known, but yet we do not have the research to back that up, that history, the longevity of that knowledge. And that we need to change. So the suffering is so severe by men, women, children, and everybody that they get pain so often, and it gets ignored. It gets labeled as something else but the pain. And I always tell my patient, pain is pain is pain. It doesn't have a first name or last name. It is pain. Doesn't matter who is suffering from it. And healthcare workers still do not see it that way, which is a shame. So we know also it affects multiple organs. And I'm a respirologist, I'm a lung doctor, pulmonologist, as you say, some south of the border. But it affects the lungs, and over 90% of the people have abnormal lung function. How many people know about it? How many people record it? How many people get treatment for it or management for it? Very few. And it affects day-to-day living, exercise abilities, participating in your social endeavors, just day-to-day being. And that still we do not acknowledge. So I started a first sickle cell lung clinic in Ottawa. I don't think there exists anywhere else what I do with the sickle cell patients in my lung clinic. But the asthma is also common, the run-of-the-mill asthma. But when they occur together, sickle cell disease and asthma, the patients suffer more. And they have more pain crisis, they have more chest crisis. And when we treat their asthma with the known therapy of asthma, their sickle cell crises are better, their chest crises are better, and we have that evidence. Still, we do not screen patients for asthma, because when they are in pain and chest crisis, it is just a pain and chest crisis because of the sickle cell. And we do not look for other entities that are vividly known from whatever minimal research that we have available, and we still do not do the justice. So overall, there are multiple organs involved, the prognosis is very limited, life-limiting disease. We do not know how much life-limiting is it. We do not have the statistics from Canada because we do not have the data from all the people who are suffering from it. So even with that, all this multi-organ disease, knowing that inherited, it's multi-system, life-limiting, devastating, all these adjectives bring to mind as a respirologist cystic fibrosis. That's the same disease, inherited, multi-system, life-limiting. Yet, we have an obvious difference. And if we cannot recognize this obvious difference of color, black and white, we are not human beings. We are inhumane if we do not recognize the difference. And that is the difference of color of the patient who suffers from cystic fibrosis and sickle cell, why the resources and the research is so disproportionate. Why the clinical care they receive in a comprehensive model is so different. And COVID-19 didn't spare sickle cell. Sickle cell patients did get more hospitalized, more crises when they got sickle cell. So on top of that, like double whammy for the patient suffering from sickle cell. And the treatment remains very limited. We had the presentations in the morning, what treatments we have, and they are very, very limited. Whereas in CF, we have a magic pill that actually cures the disease. And how did we land there? Because of the disproportionate amount of resources that are poured into cystic fibrosis everywhere. That's why we have clinical and comprehensive care centers for cystic fibrosis. And we do not have that. People get obstructive lung disease, sleep-related disease, restrictive lung disease. All these names, pathophysiologies, exist in the patient who is living with sickle cell. But yet, we do not have management, we do not have treatment, even though we recognize the entities as they are. But we do not have the disease management and algorithm, how to do that, how to treat their pain, how to treat their complication, how to treat their longevity, how to improve their quality of life. Do we have a drug to reduce discrimination? If somebody does, then we can get a startup started on that, to reduce discrimination. So these are all burdens put on the patient finally, the financial, psychosocial burden that the patient and the family bears, that some of the stories we vividly heard. And this burden is enormous, and they are trying to handle it by themselves because they don't have policymakers or the purse holders support on that. And that's what we need to change. There are profound healthcare gaps, and that's what we need to change. And how can we change that? How can we reduce the stigma? How can we reduce the racial discrimination? How can we do that? By having the data, then only we can do that. Whatever I say with my third language, English, and with my hands in the air, Dr. Ugochi Ogu very, succinctly mentioned here what sickle cell disease is, how it is related, similar to cystic fibrosis, and how we still do not have the resources that we need. The stereotyping goes on. Whenever the funding gets poured in, as you can see from this graph, the sickle cell life expectancy improved. It directly related to resources, directly related to money and policies. Making those money. If you look at the cystic fibrosis parallel graph, you see the graph is actually on a very steep incline, the improvement in the longevity of the cystic fibrosis patient. But that came with money, purse, dollar, resources. And that's why we have the magic pill. We have to change the narrative. We have to change the story. The multidisciplinary clinics that we have for cystic fibrosis, we know it works for sickle cell, and that has been shown. Why aren't we creating those? Why aren't we putting those resources in the transition care? Because the transition itself is a disease. Because if we do not do transition well, people fall through the crack and die. We recently had a death in Ottawa. So we have a very time-tested models of transition care in cystic fibrosis. Why don't we just copycat it? We don't have to reinvent the wheels. We just have to copycat it and put resources and give it for sickle cell patients. This is very simple. We don't have to do any research. It's already proven. And still we do not do that. Where do we go from here? We need more resources. We need the screening programs. We need the registry. And that's why the registry is important. And that's why the denominator of the patients is important. We only know how many went to the hospital from one hospital data. We don't know how many are there in the community. We don't know how many are there in the province or the country or globally, and we can solve all those troubles with the help of the registry. So we did launch, because we learned so much from different registries. Cystic fibrosis registry exists all across Canada and US, and we learned so much. So the first Canadian registry we launched in April 2022, and it's already now doing progress. These were the objectives when we launched it, to improve the monitoring, to get the data, to get the denomination, and finally improve the quality of life. So the Canadian SCD registry will do all of this, will generate the data, will advocate, will help in educating all those sections of the society that we talked about earlier through the morning. And we'll identify those gaps, we identify the risks, why people land up, why people get more sick, pain crisis, and who are those who are receiving still the short end of the stick. We will only know that from the data. And that data will come through very meticulously planned methods and procedures and research ethics board approvals, because we want the patient participating with informed consent so that we can publish the data. Because when we publish, then only the world will know what exists in the sickle cell patient's day-to-day life. And that's what we want to do, the demographic data, the detailed treatments, complications, why people go to the hospital, etc., etc. And we can do that, but we need your support. We need leaders from all the provinces of Canada to be the site lead. So please contact us, either me or Viva, and we can join hands. From across the globe, from Minnesota, from Germany, we can make bigger and better registry, which will be international and will be the first international registry which talks to each other. And we are in 2023, we can do that. We have so much AI, we have so much machine learning available, we can do that. So this will be the better registry than any other existing registry that we know of. And this kind of a registry will give us those annual reports to showcase that how much suffering is there, how much people are getting better or not getting better, how many people are getting care or not getting care, and how many people are surviving. That survival, mere survival statistics, we do not have available currently. We do not have. Even from Ontario, we do not have. And that's what we need to change. This narrative, unless we change, we are not empowering the patient that we really should be, The data is power, knowledge is power, and we can apply that to different kind of statistical analyses and showcase all the complications, but also the success stories. Like we heard this morning, how people get cured and why people get cured, how much it costs, what are the complications, how does it feel on the other end of the, story. So we can bring that in the limelight, and I just wanted to, I hope this video works. I don't know, audio visual person, can you help me click the video? This is supposed to be a live video just for 1 minute. I'll show you just the simple depiction of, you can play. Thank you. So the registry is simple interface of registering the patient. We can translate in French currently, that's what we have made. We'll have the consent, as I said, so that we can publish the data, the participant information, the basic, and some other quality of life measures, test documents, whatever the test data, demographic data, where people live, which zip code area they live, which part of Canada they live, which part of the world they live, what other parameters that we can contact them for, or socioeconomics, symptoms, age of onset, etc., so that this basic information is there at a larger scale. And once we have that at one place, we will learn about their day-to-day quality of life. There will be a patient portal, so that patient can register themselves, and that there will be uploads available from the patient. They can download reports, so it's very interactive. And once we have created this, and once we have gathered the data, we can then plan for the future. We can plan for a better future. And that better future would only come with this knowledge. Then only we will know how many people suffer. What resources do we need? When we go to the policymaker, when we go to the senator, what kind of resources do we need? How many comprehensive clinical care programs do we need? Where do we need them? How many transition care clinics do we need? Where do we need them? And we urgently need to do that so that we can build those comprehensive clinical programs. What kind of specialties do we need? These are the different diseases people get, and this is the burden of the disease. These many specialists we need. We need urologists, we need endocrinologists, or we need optometrists, or we need ophthalmologists. We will know that from the registry. We'll know what we need. And please contact us so that we can join hands and go together. Because I believe those damn birds, they never fly alone. They always go together, because they know when they fly together, they can go longer and faster. If we try to go solo, we will not reach there. So when we have started this registry, please join hands. Please do not duplicate effort. Because duplicating efforts meaning those meager resources you are not using properly, which is inhumane. We already have less resources. So please join hands for the sake of humanity. So when we do it together, it will be better. It has to be better. So thank you. I have a lot of people to thank because I work, as I said, community in partnership with people, and that is very hard work, as we were talking this morning on the table, and labor intensive, but very, very rewarding. And a lot of people believe in my crazy ideas, and they also give us money too, so which is good. We need money, and these are references, and please bring on any questions or comments or criticism, whatever that may be.
We're going to open it up to 2 or 3 questions because we have about 3 minutes. So, first question.
Hi, well done. Really excited about the project. I'm just curious, first of all, is the registry, what platform is it hosted on? Is it RedCap?
No, we are modern than RedCap. We are not off-the-shelf product. So the Ottawa Hospital Research Institute, where I am working as a senior scientist, will be hosting the registry, and it is all custom made from our IT department. So it is catered to our needs, what we need, not the RedCap or Qualtrics or whatever, because they have their own limitations, right? Because they are off the shelf. But we are doing from scratch so that we design the registry how we want it.
Yes, sorry, so with RedCap you can do the same, but beyond that, is there room to also include traits, or is it just for folks with
everything. The genomics data, the demographic data, quality of life data, the portal where we proactively upload the data, but patients also log in and seek information, but upload their own information. So it is patient-centered and partnered so that we have more rich data.
So what is the data agreement currently between centers? Do you have one?
So that's what we need to generate for each center. I need site leads from each center, and that's what we have created a blueprint for data agreements between the centers. We have also created that people, like suddenly somebody wants to do a research tomorrow. This 19-year-old has a bright question, writes an application, our committee looks at the application and makes data available for her. And so research, data agreement, all of this, but all these are, we call live document. We evolve,
I think she has a question as well.
It looks like that. But maybe you stole her question.
So unfortunately, I will only be able to get to you. And then after that, we'll be moving on. I'm sorry.
And I will be here rest of the day and tomorrow we can talk.
Please be aware that Dr. Pakhale and many of the doctors are here for the 2 days. If they're not, feel free to email them or find Biba to be able to contact them after that. So,
my question is very simple. Who will have access to this information? Is it between patients and doctors, families? Who will have access to the information that will be provided in the registry?
So everybody, all of the above. Because us doctors will be, gathering the data in the clinical system, because some of the data is only the electronic medical system. So we will be getting data from those electronic medical systems, so automatically data dumps. But patient will have their patient portal, so they can access data plus also upload data. Their quality of life, their questionnaire, they can upload their questionnaires. And the access to data, we all own the data. You tomorrow have a question that you want to access data, or this research you want to do, or you want to learn the facts about, you write an application, we assess what you need it for, and we provide the data. So we own the data. Ownership is all ours, the community.
Okay, so let's play out the scenario. My daughter have a crisis, she's in the hospital. How would that doctor know that, okay, she is within the registry and get all that information? Is there something that is going to indicate, or a number, something saying that that they would need access to the registry to get her file to see what's going on with her?
So that patient clinical care, we will have to create the agreement with that situation with that because registry usually is not functioning by and large. I'm talking about in the past. In the future, we might be able to do that because now we have more machine power. But registries usually is for learning about the demographic, how many people are there of this age group, and how many people are suffer from this disease, or that kind of information, like a population level information.
Okay.
But for pinpointed for this patient number X, what was there, so we might come to that, or they might contact if she knows, or we have that center partnership, then might be accessible. But we will make it more and more user friendly and accessible, because that's what it is. Otherwise, if it is covered, it's not useful.
Thank you, thank you, thank you.
So much. And I forgive you for blaming me instead of Biba.
I'll take 1 minute, please. So I want to say something about the registry. So you've seen what is in it. It is our information, our lives, your struggles, you, the warriors. We need it because it's the most important tool for us. But here is the thing. It's been years since we've been asking for one. We understand that sometimes physicians are dealing with so many things, they don't have time maybe to focus on it. But when they do, they need to work with us. You know there's nothing for us without us. This is the time to apply it. So in this room, I have all the provinces. Maybe only Manitoba is not here, but represented, I believe, but because they have a work tomorrow. This is the time where I think we have to be at the decision table from the beginning. They have to sit with us when we do this registry. It started here. We don't need to be the one doing it. We don't have the expertise, but we have the information. So when you're gonna be asked to be in a registry, ask which one you are. We're gonna come to you, we're gonna have consultation. We are planning a meeting for the registry to bring healthcare providers, industry partners, community, and we talk about it. There's going to be a national registry for sickle cell, but because healthcare is provincial, each province is gonna lead and have their own. If we don't do that, we're gonna be the one to be affected by this, and nobody else. We have to come together and work together for this, to get this data and advocate for ourselves. Anybody does it on their own, we have to tell them it is our data. So you don't help somebody by doing what you want for them, but by doing what they need. So please, we're gonna continue the conversation. Call me, let's talk about it, but we have to work on this project together. Thank you.
Thank you, Biba.